So hey, good morning. I'm Laura from Aruna Yoga. This is, I'm thrilled actually to be having this. This is our first chat in our menopause series. And Denise runs a menopause for yoga, yoga for menopause. And coming out of that have been loads and loads of questions that people have. So we have got a panel of experts and they are going to talk to us all things menopause over the coming weeks. So opening this up, where better to start than with our fantastic, I am so in love with this lady, with Dr. Janet, who is a GP, but she specialises very much in women's health. So do you want to tell us a little bit more about yourself, Janet?
Hi, Laura. Many thanks for inviting me this evening to speak alongside a wonderful panel of individuals. Looks like a very interesting evening. So as you were saying, I'm a GP with a special interest in women's health. So that's mainly menopause, long-acting reversible contraception and cervical screening. So I, along with being a GP, I've done some extra training with the Royal College of Obstetricians and Gynecologists, and I have done a 9-month community gynecology course with the Irish College of General Practitioners. More recently, I've added becoming a new mammy to my CV. So I have a little 3.5-month-old lady keeping me busy these days until I'm back in the office in January. So I'm delighted to be here this evening to talk a little bit about my experience of managing women with menopause, and hopefully it'll be of some use to some of the people on this evening.
Brilliant, thank you. So I'm just going to ask you this sounds like a very basic question, but what exactly is menopause? Menopause, perimenopause, what is it?
I know it all seems to roll into one, doesn't it? Certainly when it's happening to you. So basically, menopause is 12 months since your last period. So it's 12 months without any cycles at all, and that means that you have stopped your natural cycles and they've come to an end. There is this build-up which can go on for years before the actual stopping of the period. So that can start as early as mid to late 30s, and it's called the perimenopause or the climacteric. So that's where there's a general shift in hormones. Things are slowing down and you tend to get symptoms of menopause, but you're still getting cycles. Some women might get regular cycles or they might get more spread out. So it is kind of
best of both worlds.
Yes, I know. So one kind of tends to roll into the other. So, you know, some women will come in kind of 40s, mid to late 40s describing, classic menopause symptoms, and periods tend to spread out, and then within a year, a couple of years, then they'll eventually stop, and that by definition is menopause.
Cool. So how is it actually diagnosed then from your point of view?
The diagnosis is usually clinically, which means the woman comes into me and says, I'm in menopause, and I believe her. Because usually there's a constellation of symptoms. It's not just a hot flush, there are loads of symptoms. So I just wanted to share, I don't have many slides, but this one slide is just to show how many symptoms there actually can be with menopause. So sorry now, just share it quickly. Yeah, just make sure it's sharing on your half there. So is that sharing there?
Yeah, if you can do the slideshow, it'll highlight it up even more. Yeah, perfect. There we go. Fantastic.
So I hope you can see that also. This is called the green climacteric scale. So anyone has access to this. If you Google this, it will come up. So it's a great talking point. Sometimes I would give it to women to maybe fill out before consultation. Just it's helpful to sometimes write down exactly how you're feeling, and a lot of women don't realize how disabling the symptoms are until they're actually ticking all the boxes. So you can see they're divided into physical, psychological, vasomotor symptoms, and degrees of what their impact is on the woman's quality of life. So they're really extensive. Not every woman gets all of them. Some women get no symptoms, they're very lucky, and then some get a few. So it's a good talking point as well. So usually it's a clinical diagnosis, and yeah, we go from there then.
Okay, so is there a blood test actually required?
So yeah, I get that question a lot. So there isn't actually need for a blood test to diagnose menopause. The blood test that people are referring to is called the FSH. So it's called follicle stimulating hormone. It's produced in the brain. Okay, so in menopause, when your ovaries are shutting down and slowing down, this FSH hormone starts rising because it's saying, wake up, produce more estrogen. I'm sending this hormone higher so that you can produce estrogen, but the ovaries are not responding. So in a woman who's gone through menopause, typically you will see a high FSH, and that's where the periods have completely stopped. The downside of this blood test is that in a normal menstrual cycle, so in women in that build up to the menopause, so in the climacteric, where you're still getting periods, that FSH fluctuates naturally anyway in a normal menstrual cycle. It's highest in the first half of your cycle, it drops a little bit in the second half of the cycle. So if a woman's coming into me with perimenopausal symptoms, but they're still getting cycles, it's not entirely beneficial, or it doesn't really do anything or change our management. And sometimes it muddies the waters a little bit. Now, so there are cases where we do the FSH level, and that's in cases where the diagnosis isn't 100% clear, or in women who have premature ovarian failure. So that's women whose periods have completely stopped under the age of 40, and that would be important to make sure we get that diagnosis confirmed. And then other blood tests I would do would be mainly to, if there was an alternative diagnosis, maybe check a thyroid level if there was a query of an overactive thyroid, or I would check other bloods in terms of looking for other risk, that comes with menopause. So looking for other cardiovascular risk factors like high blood pressure, fasting cholesterol, or fasting glucose for diabetes, or then I would check their blood pressure and that kind of thing in an exam. So no, you don't necessarily need to do blood tests to diagnose it.
Okay, cool.
Yeah.
And so then in terms of, because you just listed a lot of things that is regularly checked whenever I go to see a GP. So if we were going in, if somebody approached you for a consultation, what would they sort of expect? What would happen?
So in general practice, there's a varying range. So all GPs have training in obstetrics and gynecology, but there's a varying range of, some GPs have done extra training, and so they might have a little bit more particular expertise in that area. Some practices offer particular woman or women's health checks or menopause consultations. I would definitely recommend that kind of pattern as opposed to the general GP consultation, which we all know is 15-20 minutes. Usually go in, you have other issues, and then if the menopause is the fifth thing on the list, it just isn't enough time to deal with. It's such a vast area. There's so many things to go through, all the symptom control. If you're talking about HRT, to counsel a woman on HRT, you need to go into the other things that are really important with, menopause checks, such as osteoporosis risk, cardiovascular risk. So that tends to be what I would do in a full check. I would go through their history, go through all that, do a full exam, opportunistically check if they're linked in with screening, cervical screening, all that. And then HRT is such a minefield. It does take a while to, answer all the questions, go through there's loads of options, and every woman is different. One formulation of HRT will be, suit one woman more than another. So it is kind of trying to tease that out, and having enough time for me is essential, because I really don't like half doing it, because it's such a vast area.
Okay, cool. Yeah, because you mentioned all of the sort of options with the HRT. So it's not just a one standard fits all.
No.
And it's not for everybody.
No. So HRT options, I'll try and explain it in as easy as I can. So in HRT, so the two ones we know, it's hormone replacement therapy. So it's different than, say, the combined contraceptive pill. So you go on the pill to prevent a pregnancy. So those hormones in the pill are much higher than what's in your HRT, because the pill is designed to shut off that natural axis so that your ovary doesn't release an egg, whereas HRT is just a supplement to what you are naturally losing. So there are two hormones, it's estrogen and progesterone, okay? So the estrogen is replacing what we're losing, and progesterone is there to protect the lining of our womb. So in a woman with a womb, you will always need to give a progesterone with it to protect the lining. In a woman who has had a hysterectomy, then you just need to give estrogen, and it's easy. So the options then, estrogen comes in a few different formulations. It comes in tablet form, it comes in patches, sprays, gels. Progesterone comes in tablets, either you can take by mouth or vaginally. or there's the intrauterine device. The Mirena coil is the only device that's actually licensed as the progesterone part of HRT. And then even adding more complexity to it, it depends on if you're still getting periods. So if you're still getting periods, but you have menopausal symptoms, then we need to give the HRT in a way that you still get a little bleed once a month, because that's really important for the health of the lining of your womb. Whereas women who are more than a year after with no periods, then they have very little lining left there. So you can just give the hormones continuously. You don't need any withdrawal bleed. So they're the kind of two most common, without confusing it too much. The third thing, or the fourth, actually two other points to include, is testosterone supplementation. So a lot of women don't realize that when we go through menopause, we actually lose some of our testosterone. 50% of our testosterone is actually produced by our ovaries. And the other 50% is produced by a little gland on top of the kidneys called the adrenals. So testosterone is really important for libido or sex drive. So in women, it would be a very important thing to review when you start a HRT formulation. That would be one thing to review when the woman comes back in 6 to 12 weeks, because if it's not improving on your HRT that you've given, she would benefit maybe from testosterone supplementation. The most common form is usually in a tablet, or there's a gel as well. And that would need, blood monitoring just to keep an eye on it at the start, make sure the levels are okay. And then usually most women respond quite well to it. The other thing is these other symptoms to add more fun to the constellation of symptoms. There are genital symptoms of menopause, which generally a lot of women describe it as like a vaginal dryness, discomfort, maybe during intercourse. Some women get bladder symptoms secondarily as a result of it. It's just where we lose our natural kind of lubrication down there as the estrogen drops. So it's really important that the patches and the tablets and all that, it might not necessarily address that area. And there's a whole range of pessaries, gels that are applied locally down there that do brilliant, like a lot of women, describing maybe heaviness with prolapse symptoms or overactive bladder symptoms, that kind of thing. It really, really does help. And there's very little absorption into the system of the hormone when it's used with the vaginal pessaries and that. It's even safe in women who have had breast cancers, but it would need to be prescribed, under supervision. So that would be the kind of the main prescribing in a nutshell. Sorry, now I hope I haven't confused it.
No, that's fantastic and really clear. I like that. Can I just ask you, are we looking at supplementing hormones over a period of time and then weaning people off it, or do people stay on HRT then indefinitely?
Yeah, that's a good question. So again, the usual start point, and it kind of crosses with risk benefit kind of ratios. So usually it's very topical with the risk of breast cancer and HRT. Looking at it up to the age of 50, there's no proven increased risk of breast cancer with HRT. So in women, say I was saying with the premature ovarian failure, the benefits of HRT would far outweigh any risk, because they're at such higher risk of osteoporosis and cardiovascular disease and all that. So over the age of 50, there is a slight increased risk, and it's in trials that have been done, it's only really shown to be slightly increased after kind of 4 to 5 years of use. So it's showed maybe an extra 7-8 cases per 100,000, so or 10,000. So it's not a massive increased risk. And I actually have another slide to show that there are other modifiable risk factors that are far greater link with breast cancer than HRT. So just to kind of put it in perspective, I'll just show you this slide. It's just really easy to kind of show the risk. Sorry. So this is just an infographic from the Women's Health Concern. So you can kind of see at the top. So in hormone replacement therapy, there's an additional 4 cases in women on combined hormone replacement therapy per 1,000 women. Okay. But if you look at, say, down, if you're overweight or obese, there's an extra 24 cases. Alcohol, again, an extra 5 cases. Smokers, an extra 3. And then protective factors such as exercising 2.5 hours a week is protective for breast cancer. And yeah, so it's just kind of looking at risk, and you know, when you take it into consideration the benefits of HRT, which I'll go into, and you know, you have to look at the woman in front of you, and if they're getting disabling symptoms, then it's a no-brainer. HRT will benefit them. So yeah, I don't know if that answers your question. Sorry.
Sorry, I suppose my question was more because it was more kind of philosophy kind of question, like if
Yeah.
ultimately our hormones are changing so that by the time we're 60 or 70 or whatever we're in a particular state. My question was more, is HRT support to get us through that transition, or
Yeah.
is it
is it
that
a
was more
lifelong
kind of
thing?
what I was thinking.
So sorry. Yeah, so then that gets me on. So 5 years is kind of the starting point where we know the risk isn't massively. If the benefits outweigh the risk, we continue. At 5 years, I would generally review a woman and see how her symptoms are. If she is, you know, completely 100% not getting any disabling menopausal symptoms, wants to go, you know, reduce it or go off it, I would tend to change to the lowest risk formulation of HRT. So I'll go into risk and benefit after, but I would change to a transdermal option, which is through the skin, so they're lower risk of blood clotting and that kind of thing. Generally, over the age of 60, 10 to 15% of women can still have vasomotor symptoms like the hot flushes and that, so they might need to stay on it, and some women stay on it and they're fine as long as they kind of touch base for the reviews and keep up with their breast check screening and that kind of thing. But no, you don't necessarily need to be on it forever. If that woman comes to me at 5-7 years and says, okay, I want to try weaning off it, then yeah, you can wean off, but very gradually. You know, I wouldn't, you know, if the patch was, you know, twice a week, I would maybe space it out to every 4 days, every 5 days. You know, try and reduce the dose down, change the route, change to a patch, and just see their transdermal option, and try and get them off it if that's what they want. But no, not every woman needs it forever, certainly not.
Cool. So maybe the benefits then, if you're willing to dive into all of the benefits, because I'm already excited about the benefits.
Yeah, so benefits, so symptom control, it really helps with a lot of those ones on the green index. So the hot flushes, the irritability, the difficulty sleeping, concentration, brain fog. You know, it's I've women that are literally transformed after 6 weeks. They'll come back in and say, my God, I'm like a new person. Everyone is happy to be around them. You know, they literally are where some women are at their wits' end when they come in, you know, and you know, it's really hard trying to deal with all those symptoms, and you know, we've such a massive role in society to have to keep going. But other than the symptom control, it has a protective role in cardiovascular disease as well, because we know that when we lose estrogen is protective for cardiovascular disease. So going through menopause does kind of increase our risk of that. So it has been shown to have a protective role. With that, it's important to highlight that the studies when it shows the benefit, it's starting HRT within the kind of 10 years of going through menopause. It's shown to probably the risks outweigh the benefits if you're over the age of 60, or if you are more than 10 years since your menopause onset, then it would be slightly risky to start HRT having never been on it, because it can trigger cardiac events and that if you've never been on it. But before that age, you know, within the 10 years, it's actually beneficial. It's been shown to be beneficial. There have been some studies that they're still working through it, but that it can protect against the development of dementia, because there are estrogen receptors in parts of our brain associated with memory, but they still have to do more studies with that. Risk of fragility fractures, so bone density is reduced while taking HRT, and then there are some studies that show that it might improve muscle mass and strength as well. So there are a lot of benefits to it, you know.
Okay, and then the other side.
The other side.
Side effects.
The side effects.
You get nothing for free in this world.
I know. It's a trade-off, isn't it? So side effects, really, they're not as, I suppose, because like I go back to the combined hormonal pill, they're much higher doses. You're more likely to see them with this as opposed to HRT. And usually when the woman comes in with the side effect, often just changing the dose or changing the route of administration or changing the type of progesterone often solves it. And so I try to tell women to give it a chance and don't just throw in the towel and, we'll work through it and there's other options, But I suppose estrogen side effects would commonly be bloating, fluid retention, breast tenderness, nausea, and headaches. They're the kind of top ones. Progesterone side effects would be headaches, bloating, and mood swings, PMS-like symptoms, which, a lot of women might be getting anyway. So they're kind of happy to try it out and see how it goes. But generally, just titrating the dose and changing around to a different option might just alleviate those few side effects,
Okay. And then as opposed to side effects, risks, which we've already touched on that a lot, really. Is there any additional risks?
Yeah, so the I suppose the one I was talking about was with breast cancer. I did kind of go into it, so I won't go into it again. But yeah, like as little as eight cases per 10,000 women extra per year, usually over after 4 to 5 years on it, up to the age of 50. There's no increased risk. Blood clotting, so that's a clot in your leg or lung. There is a slight increased risk with oral HRT, so that's taking the tablet form. Some studies have shown anywhere between like 9 and 18 cases per 10,000. But in transdermal preparation, so that's the patch or the gel, they didn't show any increased risk compared to the background population. So I love the transdermal options. They're kind of my first go-to prescription because there's no increased risk with clotting. They're really easy. They're more favorable in women, say, who have a higher BMI or who might have other risk factors for clotting. So I just like the transdermal, but like oral HRT is brilliant as well. And it tends to be higher dose as well. But the advice is always start low and titrate up and try and get the minimum dose that controls the symptoms rather than starting high and going back the other way, So they're kind of the main risks with it, the main controversial risks anyway. But yeah.
I'm sorry, a question just came into my head. Is it possible, I mean, can you take the testosterone or some of the vaginal dryness or that sort of side without taking full HRT? Is that? Yeah. Or are they add-ons?
Certainly, yeah. I have women that come in and the only issue, that's why the consultations take so long, because you have to tease out the symptoms and that. But yeah, I'd have women that would come in and they just have, genital symptoms of menopause. And yeah, certainly pessaries away you go and they're happy out. They don't have to, take the full blown thing. With the testosterone, I'd rarely have women on their own on testosterone because usually they'll have the other symptoms, and HRT is kind of the standard HRT preparations are the recommended go-to. There are other forms of HRT. There's one called Tibolone that has an androgen effect, which is like an effect on the sex hormones as well. So if that's a really predominant symptom, that might be an option to go for rather than the other formulation. So it depends on the symptoms and the woman in front of you,
Yeah. And so other than HRT, what are the other kind of options then that if someone doesn't want to go down the HRT route but is looking for support?
Okay, so the first line we always say is HRT because it's, there's loads of evidence it works. So the second line, so if you're looking at non-hormonal, so in women, say, who can't have HRT, say a woman who has had a hormone-dependent cancer, like a breast cancer, it's not really safe to start hormone replacement therapy in them. So you would look at kind of non-hormonal options. So there are medications, there are SSRIs and SNRIs, so they're usually used in treatment of depression, anxiety, but they have been shown to help with vasomotor symptoms in menopause as well. But again, they're second line options. There's another medication called clonidine. It has also been shown to help with the hot flushes, but again, not as effective as HRT. And then over-the-counter preparations, there's things like isoflavones and black cohosh and different things. There isn't any really strong evidence with them. Like some women feel that they help, but I'd just be a little bit cautious with over-the-counter preparations because some of them can affect liver function. I did have one woman, I can't remember exactly what it was, but it just, you know, just be careful, read the small print on them. Just because they're over the counter, you know, you can do damage. So just be careful with that. And then the other side of it is cognitive behavioral therapy has been shown to help with, you know, low mood, anxiety secondary to menopause as well. So we'd always recommend that as a supplementary therapy. It's not going to hurt anyway. But they're the other kind of options if you wouldn't like HRT and you want to try something non-hormonal as well, you know.
Okay. And just for sleep, would you be recommending sleeping tablets, or would you go for, again, more the CBT or the
No, we hate sleep
meditation, dare I say?
No, we don't like, we call them Z hypnotics. We generally don't prescribe sleeping tablets because there's a big study that came out about them and their effect on memory. In the long term, they're very addictive. You know, you can develop dependency and you might need higher doses of them to exert the same effect in the future. So we try not to prescribe them. Generally, as a byproduct of all the other symptoms, HRT will help with sleep. Because you're not going to be sweating, you're not going to be stripping down the bed sheets and changing your clothes every 20 minutes when you're in bed, and it tends to just balance things out. So I would have a lot of women that sleep would improve on HRT, but no, I wouldn't be a lover of sleeping tablets now myself.
Cool. Brilliant. Well, I would strongly recommend meditation.
Yes.
Yoga.
Well, that's the part of it. Yeah, definitely. No, it does help. You know.
Cool. And so if people want to access more information, you know, there's so much information on the internet, but like how much of it is reliable or safe or you know?
Yeah, I know there's loads. If you Google menopause, all these opportunistic things come up. There's one called Menopause Matters. It's very good reading. You know, it's easy to follow and it is evidence-based. I have a little slide where I've shared others. Now, some of them might be more kind of medical based than others, but it's worthwhile. Kind of, I can share it with you now.
And then maybe I can include these in the.
Yeah, so there's
fantastic.
British Menopause Society is very good. Nice guidelines. Women's Health. Yeah, Menopause Doctor, Daisy Network, and then Menopause Matters is my go-to.
Okay.
Just if you're on the fence about HRT, the Menopause Matters has a very good infographic on like pros and cons. You know, if you're choosing it.
Mm-hmm. Fantastic. Wow, that's been just so much information. That's really, really helpful. Really helpful to have it, and even to have it broken down about where the options are and how it all works. You know, and my big takeaway is go to a GP that actually offers a menopause consultation as opposed to trying to fit it into the 15-minute.
Or book a, you know, a separate, like it deserves the time, you know, to go into it, like that you have enough time to get it, because it is like there's a lot in it, and it can be done really well, you know, if you just have the time to go into it, you know.
Brilliant. Is there anything else you'd like to kind of say before we?
No, not really. I hope I haven't saturated you with information there. But no, it's just, look, it's something I'm very interested in. I'm very aware I'll be facing it myself someday. So I'm always looking at new things on the market, and you know, it is something that you know, is so beneficial to women. Like, you know, there's so many women sitting at home suffering in silence with terrible, debilitating symptoms. And, you know, like I said before, we have such an important role in society. We need to be highly functioning, and we're mothers, we're working, we're doing everything. So we need to, you know, be on our game as well. So I think it is a great option. And look, you don't know if you don't try it. No one's holding a gun to anyone's head. If you try it and you don't like it, you can just stop it. You don't have to continue with it. But it's definitely worth looking into. And obviously, just keeping in mind, I'm the medical side of it. I know there's a lot of other individuals on the chat tonight. I'm very pro exercise. I'm very pro mindfulness, meditation. and just keeping that side, you know, trying to just balance everything. And obviously exercise has the benefits of helping with psychological symptoms of menopause, and also adding strength to your bones, so preventing osteoporosis. We need to be doing weight bearing exercise. So yeah, that's really it.
Brilliant, brilliant. Well, thank you so much. It's been such a pleasure and really, really useful.
Thank you.
So,
Thank you so much. Really enjoyed it. Thank you.
thank you for your time.
Take care.